acute coronary syndrome. She's taken into the ward, admitted. This is her echocardiogram at that time. You can see some STT changes in the anterior precordial leads. The next step is to undergo a coronary angiogram. And as we go through the angiogram, we'll notice that the target to fix is that LAD diagonal bifurcation. There is some disease in the circumflex ostium, and there is some minor distal disease in the PDA. Having seen this, we calculated a Gray syntax and was calculated accordingly. And she opted to go for a PCI. And with shared decision making, it was decided that the provisional single stent strategy would be the best way forward in this scenario. So doing the normal, we wired the three vessels. We've got a wire in the diagonal, one wire in the LAD, and just for over ensuring, we've got one wire in the circumflex. We're pre-dilating, prepping the lesion, confirming in multiple views to see we're nailing that ostial LAD, and we're making sure we're doing a puff IVUS that we like to call it, and making sure that we're no dial is trickling down. It helps us approximate the stunt and also what we're doing. While this is going on, we realize that we have that diagonal that we so wanted to go provisional with. There is some pinching of that diagonal ostium. So a pilot 50 wide is taken, the diagonal is recrossed, and we try to open the struts of that side ostium. While this all is going on, we realize that after removing the jailed wires, we see that there is some staining on the left main. Is it a left main dissection? The patient starts dropping pressures. We start worrying for the worst. The patient has 2 VT runs, which were electrically cardioverted. And obviously, all hands on deck approach is on Sue, and the head of the unit is called in for help, and he takes over the case. The patient is very irritable. We've lost a few wires. She's all over the table. So we decided that we take a non-selective injection of the left main. Now we see that it's less likely a dissection. It more or less looks like it is a thrombus. All our efforts to advance the thrombus aspiration device, we're trying to rewire, we're trying to balloon, nothing would go in, it would kink, and the patient is becoming unstable as the time goes by. We then do the practice that is not commonly done. We removed all the hardware, which is not the common practice. While this is going on, we decide to get another ACT done, and the ACT comes out to be 110. Despite giving her 7,500 units of heparin upfront, followed by another 2,500 of unit the second time, but there is no flow. So we've taken everything out. We're doing serial echocardiogram. During this patient, the patient goes into a brief period of asystole. A CPR of 2 minutes is done, and she comes back, and ROS is achieved. So we take a leap of faith, and we've removed all the hardware, and we're going to do this all over again. Again, we're ballooning that LAD, the thrombus leaden. It becomes fairly straightforward after that point. As long as we get some sort of a flow, we establish some flow, and we reduce that thrombus somehow so we can get some TIMI through flowing into the LAD, and we see that there is hope, and we just proceeded with doing a left main to LAD stenting, and then overlapping it with the previously deployed stent, confirming it in multiple views. And that diagonal that we sought to protect, we've actually lost it, and there is TIMI zero flow in that diagonal. So what do you do? Do you try to fish this out in a crashing patient, or you do what is necessary and just do a bailout and come out? So we decided to do a bailout. We did a tap, hybrid tap sort of a technique, and after that it was a fairly simple scenario. We recrossed into the circ. We mildly protruded that stunt into the left main LAD stunt. We did a pot. We performed a kissing technique, and finally finishing off with the final pot. And the patient is now maintaining pressures. She's doing well. She's not running any arrhythmias. It's a fairly angiographically acceptable result to come out of the cath lab with. The patient having undergone intracoronary agrostat infusion, agrostat bolus, followed by an 18-hour protocol. She was making a fairly good recovery until the night before she complains of mild chest pain. So what do we do? Do we go and restudy her again? Have we done something else? So the plan was to restudy, hoping for a silver lining. And indeed, there was a silver lining. That diagonal has come back. That's a good sign. And her LV cine shows that her EF is preserved. She's running a good LV. So take homes from this scenario is that always call for help. Always involve your seniors. Swallow your pride. always announce your ACT levels and heparin doses in the cath lab. Left main disease distally, IVUS is must in left main PCI, even to diagnose. And always go in a case expecting the worst and always rehearse your checklist. I thank you for your attention.